My name is Jeff Lancet. I'm from the Moffit Cancer Center in Tampa, Florida. And one of the questions that has been coming up a lot recently is whether we are in a transition phase for treatment of acute myeloid leukemia towards an all-oral regimen. And I think with the advent of oral decitabine and cedazuridine, that becomes a distinct reality. We already know that HMA plus venetoclax has emerged as an important standard of care for older, less fit patients with AML as primary therapy. And now, with the addition of oral decitabine, there's certainly the opportunity to convert that to an all-oral regimen. And with most of the new targeted therapies also being oral-based, we have the opportunity to extend this potential oral regimen into even larger subgroups of patients that happen to have specific targeted or specific mutations that can be targeted with novel therapies. We'll be seeing some updated information here at the ASH meeting looking at some of these novel combinations, including oral decitabine plus venetoclax as initial therapy for older, more frail patients with AML. We'll also be seeing some early phase studies that are combining oral decitabine with venetoclax with a targeted agent such as an IDH inhibitor or a menin inhibitor. And certainly the early data in these triplet combination all oral regimens looks quite promising. And we'll be looking forward to seeing how these data mature and what the overall safety and efficacy profile looks like down the road. Certainly we're going to be experiencing challenges when it comes to an all-oral regimen because of the fact that we will be transitioning more patients to community-based practices where this can be done more easily than perhaps parenteral-based therapy or more intensive therapy that requires hospitalization, oftentimes at an academic center. So it's going to be very important to ensure that there's a constant level of care, a standard of care that exists that ensures the safety of these patients when being treated in the community, because there are unique side effects and toxicities that are not always predictable and can be difficult to manage in the outpatient setting, such as infectious risk, differentiation syndrome, and others. So as these all-oral therapies that are primarily outpatient-based evolve, we're going to have to see an evolution of communication between primary and community oncologists and academic oncologists to ensure that there is an excellent and appropriate standard of care that provides the best possible outcomes for these patients.